And starts with perforated ulcer. Is a complication of gastric ulcer and maybe localized in the duodenal part of digestive tract. A perforated ulcer is characterized by the appearance of through the defect in the wall of stomach or duodenum in the center of a chronic or acute ulcer, which can open into the free abdominal cavity, mental bursa, or retroperitoneal space. Etiology with a complication and pathogenesis. The acceleration of the clinical course of gastroduodenal ulcer most often occur in the spring and autumn. It is at this time of the year what the largest number of perforator is observed. There are local or general factors what contribute of these complications. Usually perforation is present by the intake of spicy and plentiful food, alcoholic beverage, leading to the increase in the intragastric pressure, a decrease in the protective function of the gastric mucosa, and an increase in acid peptic production. The physic factors and physical fatigue are absolute importance in the perforation. Also, attention is drawn to local microcirculation disorder in the ulcer area in the form of stasis hemorrhage, tissue infiltration with a high content of eosinophils. There is no doubt what it is the violation of microcirculation, trophic disorders, and would lead to tissue necrosis and perforation of the ulcer. And it is believed what outer sensitization plays a significant role in the development of ulcer perforation. This confirms the presence of outer antibiotic to the gastric mucosa in the bloodstream of patients with perforated gastroduodenal ulcer. Classification by of perforated ulcer in Russia. Use classification Savelyev. I don't know what's classification. Maybe in your country, maybe common sentence with the classification. Classification Savelyev divided on etiology, localization, clinical forms. Etiology may be perforation of chronic ulcer and perforation in the results acute ulcer. Acute ulcer, it means maybe hormonal stress after trauma, after big operation, maybe. Dependent localization, maybe stomach ulcer and duodenal ulcer. And also you must stick what parts of stomach ulcer or duodenum ulcer are present in this course. And the clinical forms may be next typical and atypical. Typical it's means perforation in the free abdominal cavity. Atypical it's forms cover perforation of tools into the mental bursa, into the retroperitoneal space. For example, if your patient with has ulcer, duodenal ulcer. And also maybe perforation into the small and large amentum and eject organs, micro perforation maybe, and in this case you may see little small things of with perforation. Next maybe perforation combinations. With bleeding, now, for example, maybe perforation plus bleeding. Bleeding maybe into the gastrointestinal tract, maybe in the free abdomen cavity. Maybe perforation plus stenosis, perforation plus penetration, maybe. No, it's more severe condition of your patient, and this patient study with condition, you must during education in the postgraduate in the ordinatura special education, surgical ordinatura, for example. And also maybe in this classification I must talk about classification phase of peritonitis, because always tension, always if you see patient with perforated ulcer, present peritonitis, maybe little, maybe one part of abdomen cavity, maybe total peritonitis, maybe different change, fibrinosis, purulent peritonitis, but always present symptoms peritonitis. And what are next phase periods of peritonitis? First, it's a clinical peritonitis, maybe different source, different books you read about name of with periods of abdominal shock. Secondary, it's bacterial peritonitis and the systemic inflammatory response syndrome, and last, diffuse purulent peritonitis. And sepsis. Так, next. Sorry. Ага, все, это пошло. Okay. So next, clinical symptoms. Period of abdominal shock, maybe period of emergently well-being, and period of generalization peritonitis. Also, perforation develop quickly with pronounced symptoms. In 20% of patients, it is possible to identify of a prodromal period. Prodromal period increase pain in the 3 to 4 days. The appearance of nausea and vomiting. Perforation is accompanied by the classic triad of things. It's a triad described Mandor. According to Mandor, 3 main symptoms. Danger pain in the 95% you see these symptoms. Next, secondary symptoms. Board-like tension of abdominal muscles in the 92% present with symptoms. And last, prevision history of ulcer. It's triada Mandura. In the typical course of perforated gastric and duodenal ulcer, 3 periods and are conventionally distinguished, which correspond to a phase of development of peritonitis, but have some of their own characteristics. Итак, so first periods are the first 6 hours. During these periods, make pain syndrome is not danger pain. Bradycardia, board-like tension of the abdominal muscles. On our lessons, I speak about in the Russia present name of this pain, похож на удар ножом. It's like beat of knife. Very sudden, very danger pain, and very often patient answer correct time starts with clinical symptoms. Next, sorry, next period, secondary periods, last from 6 to 12 hours after perforation. In contrast to the periods of shock, the pain syndrome is not very pronounced. Patient subjectively note an improvement in the well-being pain on palpation. Tachycardia maybe persists. And next period, last period after 12 hours, after perforations, things of progressive peritonitis, and in these periods you see clinical symptoms of peritonitis. Что-то у меня сегодня не хочет. Change slide. Okay, good. So, the first periods of abdominal shock corresponds of a sudden onset of acute dangerous pain in the epigastric region, Dieulafoy syndrome. It's syndrome Dieulafoy. The pain is initially localized in the upper abdomen part. With perforation of a duodenal ulcer, pain may be localized more to the right of the midline. Quite quickly is spreads along the right half of the abdomen, include the right iliac region, when capture all its parts. There is a characteristic irradiation of pain in the right shoulder, supraclavicular region, and right scapula, which depend on irradiation of the phrenic nervous endings as a word, as a name, Phrenicus syndrome, Phrenicus irradiation. Vomiting in this period, it's not typical. It can occur with perforation of stenosis, pyloroduodenal ulcer against the background of the stretching and full stomach. In viscous vomiting may be present perforation. Its role is occur much later with the development of diffuse peritonitis. The appearance of the patient in the first hours of the disease has its own characteristic. The face is pale, haggard, frightened, cover with a cold sweat. The position of patient is a horse on the back, or more often on the right side, with the long extremities brown to the shaped tense abdomen. The slightness of movement in viscous increase the pain in the abdomen. Body temperature is normal or maybe low. The pulse is well felt, slowed down to the 50 to 60 beats per minute, and also it's the symptoms, Grekov symptoms. And also maybe moderately speed up 80 beats per minute, blood pressure is reduced. The stomach is not involved in the breathing. Breathing is a shallow rapid. Attention is drawn to the tension of abdominal muscle, which is described in the literature as a board-like abdomen, wood-like abdomen maybe. In Russia, present a name for these symptoms – доскообразный живот. То есть живот похож на доску. Muscle tension has a tonic character. And in young people, buff rectus abdominal muscles appear in relief in the form of longitudinal shafts separated by tendon bridge in the transverse direction. Muscle tension may not be as pronounced in patients with flabby abdominal wall. It may also be absent in persons in state of alcoholic intoxication. It is also hidden by abundant subcutaneous fatty tissue in obesity people. So next palpation, palpation and abdominal percussion, sharply painful. The greatest soreness with percussion is usually localized in the upper abdomen. No, symptom Schoenberg always positive. The presence of free gas in the abdomen cavity, pneumoperitoneum, and the diaphragm in the 75 to 80%. Or under the liver is characteristic things of perforation of hollow organs. When free gas is found in the right subphrenic space, the patient is placed on the left side and percussion is performed along the right mid-axillary line. In the course of perforation, instead of the usual dullness of the percussion sound of the liver region, tympanic is detected, and ELSA is symptom, name of symptom, spirometry symptom. The disappear of hepatic dullness, Clark symptoms can be detected in the absence of perforation due to dislocation of the swollen transverse colon when the latter is located in the front of the liver. In the course of massive adhesive process in the abdominal cavity, gas may not appear at all. Already from the first hours of the disease in the number of course, it is possible to detect a sharp soreness of the pelvic peritoneum with digital rectal and vaginal examination. It's a Kuhlenkampf symptom. And also other symptoms typical which are present has names, but it's more often used with symptoms and что ж такое сегодня не нажимается? Вот. And I think in your country also present with names with symptoms. Next secondary periods of emergently well-being. The patient face takes on a calm look, pulse, blood pressure, and body temperature are equalized. Breathing occurs to be superficial. The pronounced symptoms are smoothed out. The patient's well-being improves and abdominal pains decrease. Positive dynamics in the patient condition can mislead both the patient and the doctor. Patients during these periods are reluctant to examine convinced what the disease has already passed or will pass as soon as this change harm. However, with careful analysis of the data of clinical studies, it is possible to identify and increase in the signs of developing peritonitis and increase in pulse and respiration and increase in body temperature, intestinal paresis, and also you see leukocytosis. Next, the tongue during these periods becomes dry and cold. The muscles of the anterior abdominal wall are less tense. During palpation, pain in the upper section nevertheless, and the right half of the abdomen will persist. examination of the navel with fingertips will cause soreness due to irritation of peritoneum. No, it's a Krymov symptom typical for Russia. I don't know, maybe, and in your country also, maybe famous with symptoms. Pain in the upper abdomen can gradually subside if the perforation of the ulcer is covered. Pain may appear in the right iliac region. Local muscle tension in the thumb project this occur due to a leakage of gastric or duodenal content along the right lateral canal and accumulation of peritoneal exudate in the right iliac fossa. If the doctor sees a patient for the first time, it is during these periods without having collection, a prepare analysis, what he can make a mistake and diagnosis acute appendicitis. In the next last periods, third periods, the periods of generalized peritonitis occur 12 hours after moment of perforations. The patient's condition is progressively worsening. The first symptoms of progressive peritonitis is rapid vomiting. The body temperature is feveric, sometimes lower, tachycardia, you see with patients, weak feeling pulse, blood pressure is lower, the patient is restless, the skin and mucous membrane dry. There is development systemic inflammation reaction syndrome. Tongue dry, densely coated with a darkly brown blood. The abdomen is swollen due to intestinal paresis or rate paralytic intestinal obstruction. The abdominal wall is stretching and tense, elastic tension. Painful on palpation and percussion, you may determine. Abdominal region may be observed when the abdominal wall is pulled upon inhalation simultaneous with the rise of the chest. Bloomberg symptom is shaped positive, is a result of reflex contraction of the muscles, what's left of the testicle and the superficial fascia of abdomen. Genital symptoms appear, pulling up of testicles to the external opening of the inguinal canal. The penis turn its head up parallel to anterior abdominal walls. Its symptoms maybe see and read Bernstein symptoms. And else during this period, peristaltic nodes are usually not here. What's the symptom of diet silence is determined, which indicate paresis of intestinal. At the same time, when the patient's torso is rocking, it's possible to determine the noise of the splash of free fluid in the abdominal cavity, get Schlichten symptoms. And the next may be determined Gusten triad. The spread of sound through the abdominal cavity stretching, which gathers to the level of the nerve. Peritoneal friction, reminiscent of pleural friction, in the costal margin or in the epigastric region. A metallic tingling noise what occurs when inhaling and is associated with the presence of free gas link the stomach through the perforation in the surrounding fluid. Head syndrome, head sound can be heard through the anterior abdominal wall down to the level of the navel. Guston symptoms it's. Next, you must use laboratory research, investigation, and laboratory data reveal leukocytosis with a shift in the leukocytes formal to the left. Hemoglobin and hematocrit increase as results dehydration, decrease in the BBC. In biochemical studies, violation of the water electrolytes and acid-base studies state are not, which is manifested by hyperglycemia, metabolic acidosis, and increase in the content of urea and sorry, I am repeating, increase urea, creatinine in the blood. You may see atypical perforation is rare. Also is perforating the retroperitoneal space, which are located in the cardiac part of stomach and posterior wall of duodenum, with is extremely not rare. Usually penetrate into the pancreas, which is complicated by profuse bleeding. In the first causes, gas from the stomach can penetrate into the mediastinum. The fiber of the left supraclavicular region gas from the stomach can penetration in the mediastinum. It's Korach syndrome, Korach syndrome, and characterized the fiber of the left supraclavicular region of the left side wall of chest, where body cause subcutaneous emphysema. In the second cause, subcutaneous emphysema appear in the navel, air sprayed from the retroperitoneal tissue along the round ligament of the liver, and in the right lumbal region, Vigilance symptom also maybe. Perforation also of a leisure or great curvature of the stomach into the space between the sheet of peritoneum of the laser and great amentum is accompanied by occurrence of an inflammatory infiltrate, and when it's abscess. Prolonged persistent muscle tension in the right upper quart of the anterior abdominal wall with the general good condition of the patient is characterized of common perforation of stomach or duodenum. If speak about atypical perforation, posterior wall of stomach into the thickness of leisure of or great amentum, clinical manifest themselves differently when perforation into the free abdominal cavity as a result of the ingress of gastric contents into the amentum bursa. Amentum bursitis develops from the amental bursa. The contents through the Winslow wall can enter the free abdominal cavity. This leads to the development of generalized peritonitis, maybe. So, next step you must do instrumental method diagnostic and more important roles is X-ray investigation to establish the diagnostic of perforation ulcer in additional anamnesis and physical diet, laboratory and instrumental examination, and data of a general clinical blood test in the first hours after development of complication remain unchanged. With the development of peritonitis, leukocytosis rapidly increase with a shift of leukocytosis count to the left. In urine test for peritonitis, the appearance of blood corpuscles, proteins, and cylinders is notched. Instrumental method examination, it's X-ray examination should begin with a plain radiography of the chest and abdominal cavity. Attention. You must do two scan, X-ray investigation chest and secondary X-ray investigation abdominal cavity. Survey radiography of abdominal organs with perforation and hollow organs reveal free gas under the right side under diaphragms. The accuracy of X-ray methods depend on the amount of gas what enters the free abdominal cavity. For patient in the serious condition, it is advisable to carry out an X-ray in the lateral position, with while free gas is localized at the place of attachment of the diaphragm to the lateral wall of the abdomen. Next method, if after X-ray investigation you doubt, you don't understand present or absent perforation, today next step you must use fibrogastroduodenoscopy. During my lesson I many time speak about 20 years ago, 20 years ago, fibrogastroduodenoscopy was contraindication for perforation peptic ulcer. Today, present there is a recommendation maybe use this method for diagnostic for difficult causes for diagnostics perforate of this ulcer. This method makes it possible to clear diagnostics in difficult only causes, to give to exact localization of ulcer in the size to detect the state complication. State complication, the presence of secondary second ulcer with bleeding or free of development things of stenosis. Perforate ulcer of the anterior wall of duodenal bowel seen through the perforation of turbid effusion from the abdominal cavity. And also, if you have doubt, present or absent perforation, the last step, attention, last step for determine present perforation peptic ulcer, you may use invasive method investigation. It's laparoscopy. It helps to clarify the diagnostics and choose an objective treatment plan in course of in a comprehensive clinical picture. And in the some cases, it allows you to make sure what one or another types of operation is possible. So, perforation of stomach or duodenal ulcer is absolute indication for surgical treatment. Guideline, international guideline in the Russia present protocol of treatment, only surgical treatment. Before surgical intervention, the patient is obliged to probe to the stomach, following by aspiration its contents. A catheter is inserted into the bladder. Hygienic preparation of the operating field is carried out. In the event what the patient condition is severe and is due to diffuse purulent peritonitis, together with the anesthesiologist, intensive infusion therapy is prescribed and carried out for 1-2 hours. The operation is performed under combined endotracheal anesthesia. It's also possible to use epidural anesthesia corresponding hypovolemia. Most often for surgical access when performing surgical treatment of perforated ulcer, laparotomy is used. Midal laparotomy. Midal laparotomy. It's gold standard of access for this patient. After the surgeon detects the perforation, he must decide to resect the stomach, suture of a perforated wall, the excess of ulcer by pyeloplastic and vagotomy. The type and the volume of surgical is determined intraoperatively, strictly individual, depend on the nature of ulcer. The time elapsed since the moment of perforation, the severity of peritonitis, the age of patient, nature and severity of concomitant pathology, and the technical capable of operating them. Suturing of a perforation ulcer is indicated in cause of diffuse peritonitis. What means? It means with a perforation time after more than 6 hours and a high degree of operation risk. If patient has severe contaminated disease and all ages, only use suturing. Don't use resection. Repeat, and repeat. Only suturing. Mini operation. In the young patient with the fresh ulcer, without visual signs of chronic process and an ulcer history in the cause of perforation of symptomatic stress ulcer. Suturing of perforation of the stomach wall is perforated by imposing 2 rows of interrupted serous muscle sutures in order to avoid narrowing the lumen of the pyloric part of stomach or duodenum. The perforated hole should be sutured so what the suture line is transverse to the axis of the organ. Endovideo surgical suturing, laparoscopic suturing of perforated ulcer is possible with the appropriate equipment of a medical institute and the qualification of doctors. Today, fortunately, in the many clinic has impossible do with a laparoscopic operation. It's very good, and I am happy with tactic. To date, suturing of perforated gastric or duodenal ulcer is one of the most commonly used types of laparoscopic intervention, characterized by simplicity of technical extrusion and low trauma. So, excision of the perforated ulcer with pyeloplastic and vagotomy is performed with a perforated ulcer of the anterior wall of the duodenal bump without significant inflammatory infiltrate. Gastric resection is indicated in the cause of chronic calculous gastric ulcer, even more so if the malignancy is suspect, as well as in decompensate piliary duodenal stenosis. This operation is possible under the following condition: absent of diffuse fibrinous purulent peritonitis, which develops 6 hours after perforation. The patient's age is less than 60 years, and the absence of severe concomitant disease. Suffice qualification of surgical and available of condition of this technical complex operation. Resection is performed as a rule according to the Bilirut 1, Bilirut 2 methods, modified by the Homster-Finsterera with long duodenal. Also, technique difficult in processing the duodenal stops. It's advisable to perform an anastomosis according to rule. And I repeat, better finish your surgical treatment only suturous, because there are many risks break with anastomosis, with results, bad results after your resection. Next complication: piliary duodenal stenosis. The causes of piliary duodenal stenosis in the 80% of causes is recurrence of duodenal ulcer. Much less often, narrowing in this zone develops, which ulcer of the prepyloric and pyloric parts of the stomach. Violation of the movement of food leads to increase work of the muscular wall of the stomach. Its hypertrophy develops. Over time, compensatory opportunities deplete. The stomach increases in volume, its wall becomes thinner. The stomach does not empty completely. Stomach congestion leads to vomiting, which are progressive over time. Vomiting leads to the loss of fluid and electrolytes. Hypochloremia, alkaloids develops. There is a violation of calcium metabolism, which causes the appearance of seizures. Hypokalemia leads to muscles weakness, paralysis, and paralysis starts and often have these patients. Classification of stenosis: functional, maybe, or anorganic, maybe compensate, subcompensate, or decompensate. Maybe classification according to the degree of inflammatory deformity of pyloric and Baum into small, moderate, and severe deformates. Next. More often in the clinical classification use compensate, subcompensate, and decompensate. Stages of stenosis. With compensate piliary stenosis, there is the rate narrow of outlet section. However, due to hypertrophy of stomach muscles and increased motility, food evacuation from the stomach occur at standard times. Slight regurgitation of stomach content into the esophagus is possible. The general condition of the patient as a rule does not change, but the following symptoms are characterized: sharp peristaltic movement of the stomach are possible, visible in the when people through the abdominal integument, which is a characteristic of pyloric stenosis. Excessive secretion of gastric juice, belching, excreting heartburn, vomiting, large amount of gastric juice, suffocation due to the reflex spasm of the vocal cord. a feeling of having in the epigastric region, vomiting of recently eating food, bringing relief. During auscultation, you may determine rumbling, hyperperistalsis of stomach, and sometimes maybe determine paresis. Next method, you must use percussion. Percussion, dullness of the percussion sound in the epigastric region. During palpation, relieves soreness, pathological peristaltics, deep or large walls going from the left to right and down. Next stages, subcompensate. Subcompensate stages is characterized having and overfilling in the epigastric region, pain syndrome frequent, so belching, vomiting becomes indomitable and frequent. It appears after eating. During with the stages, patient often only may drink, don't eat big food and hard food. On empty stomach, the stomach usually contain of a lot of gastric content. The patient begins to lose weight, and the stomach evacuation is delayed by more than 6 hours. Whereas the symptoms Kussmaul, Reichstadt described above. And the last, the compensate stages, the evacuation function of the stomach is absent. Vomiting becomes systemic, pain is constant, with severe and distension in the epigastric region disappear after vomiting or gastric lavage. In the vomiting, there is food eaten every day, and also after fluid food, you may see vomiting, repeat vomiting. General condition worsens, exhaustion and dehydration progress as results of the loss of trace elements, in particular calcium, tetanic convulsion of the finger, of hand, occur under the influence of the compression of the hand for several minutes. This condition developments gastric tetany when struck with a hammer in the projection of the trunk of the facial nerve or its branches, the faces, muscles of the face contract. Unbearable pain also occur when tapping with a hammer in the area of the exit of the branches of the trigeminal nerves. Next, you must use instrumental method investigation, and more often use X-ray method, because this method help you determine correct determine what stages of this disease. So, stages 1, delayed evacuation of stomach content by contrast again is delayed for more than 8 hours. Gastrostasis, peristalsis, narrowing of the pylorus. Stages, secondly, the contrast in the stomach is delayed up to 12 hours from the moment of administration. The stomach is delayed, peristalsis is weakened, the pylorus is narrowed. Stages, third, pyloric stenosis. It means stomach is dramatically distinct. Peristalsis is sharply weakened. Contrast evacuation is not reachable until 24 hours. Treatment. In the treatment of pillar-duodenal stenosis, gastric resection are used according to the period 1 or period 2 in the modification of Hofstera Finsterera. With the low duodenal ulcer, technique diffusion in processing the duodenal stump. It's advisable to perform an anastomosis according to rule. In the decompensate stages of pillar-duodenal stenosis with accompanied severe condition of the patient, gastroenterostomy is the operation of choice. In case of peptic ulcer disease, the posterior colic anastomosis should be used since the anterior colic gastroenteranastomosis is often complicated by the development of peptic ulcer. Next complication, penetration of ulcer beyond the wall of the stomach or duodenal into adjacent organ, surround organ, and tissue. It occurs when a destructive ulcerative process spread beyond the wall of stomach or duodenum into neighboring organs, liver, pancreas, omentum. For example, ulcer of a posterior wall of duodenum and postbulbar ulcer penetrating in the head of pancreas, less often into the biliary tract, liver, hepatoduodenal ligament, and very rarely in the large intestinal and its mesentery. Stomach ulcer penetrate into the lesser omentum and the body of pancreas. There are three stages of penetration. Stages first characterized by the penetration of the ulcer through the all layers of wall of the stomach or duodenum. Next stages of fibrous fusion, which eject of organs. Third stages of complete perforation and penetration in the tissue of the surround organ. The clinical picture, clinical symptoms of ulcer penetration depend on the depth of destructive process and the organ into which penetration has occurred. The pain with the complication become constant, intense. The connection of appearance of the pain with food intake and the time of day is not traced, and the pain is not stopped by talking antacid, increase nausea, vomiting. Sometimes there are signs of inflammation as evidenced by low-grade fever, leukocytosis, increased serum. The radiation of pain depending on which organs has penetrated. If the bottom of penetration is the pancreas, patient will complain of constant back pain, aggraved after eating, and at night with the penetration of ulcer into the hepatoduodenal ligament, obstructive jaundice may develop when penetration into the lesser omentum, the pain radiate under the right costal arch, into the right shoulder and clavicula. When high ulcer penetrate, pain may be radiated in the heart region, which in the turn will simultaneous coronary head disease, and maybe you must do differential diagnostic with infarct myocardial viscosa. With penetration of post-bulbar ulcer and the ulcer of the anastomosis pain spread down to the navel. maybe different different symptoms. And next your step, it's diagnostic. Next step, diagnostic. Uh, to clarify of diagnostics and X-ray examination of stomach and duodenum should be done use a contrast medium, fibrogastroduodenoscopy and ultrasound echography. X-ray symptoms of penetrated gastric ulcer are feeling defect in the form of niche of what goes beyond the contours of stomach wall and restriction of mobility of the zone in the ulcer area. Endoscopy, it's a more informative method for determining penetration because you see a long time present with ulcer. Non-effective anti-ulcer conservative treatment. Its first symptoms, penetration ulcer, and more information maybe give CT scan and ultrasound investigation. Treatment of penetration ulcer in the absence of the effect of conservative treatment therapy is surgical. The method is performing the surgical and depends of the localization of ulcer and the topographic, anatomical, and pathomorphological features of the tissue involved in the penetration. The method of choose maybe following operation: gastric resection according to Billard 1 or Billard 2, vagotomy with anthrombectomy, it means economical gastric resection, vagotomy with drainage surgery and ulcer remove from the lumen of gastrointestinal tract, ulcer interiorization. But always you must start with conservative treatment. It means anti-ulcer therapy and symptomatic therapy. Next complication, malignancy. Malignancy of stomach ulcer, what is degeneration of ulcer into a malignous tumor, is quite often a complication of peptic ulcer. It's observed about 3 to 50% of patients. Clinical manifestation of early stages, early stage of ulcer, transformation into cancer do not have any quiet features. Malignancy of the ulcer may be evidenced by the syndrome of small things of Savitsky. What in the Russia described with symptoms Savitsky. What means small things? First, change in the patient's well-being expressed in the appearance during the last weeks or month of the general weakness, decreased ability to walk and repeat fatigue. Mental depression, persistent loss of appetite, aversion of meat food, phenomenon of gastric discomfort, a feeling of a full stomach, flatness or a feeling of a heaviness in the epigastric region. Injustice, weight loss accompanied by pale skin and other signs of anemia. These things are not a criteria for early organ damage. They are the results of the advanced disease, violation of the general condition of the patient against the background of enjoying blood loss during the disintegration of the tumor due to intoxication during the absorption of the products of its decay, due to septic phenomenon during the development of infection in the tumor, in the surrounding tissue. In the early stages of the disease clinical manifestation are not pronounced. However, with prognosis of the oncological process, they become more noticeable and are characterized by an increased general weakness, weight loss, change in the nature of pain, and decrease in gastric accessibility. It is possible what severe pain behind the sternum occur. It's with engine pectors. On palpation, patient can reveal dense, painless lymph nodes located above the left clavicle near the attachment of the sternocleidomastoidus muscles. Sometimes it's covered with the collar bone, it's Virchow syndrome. With percussion, there is shortness of the percussion sound at the level of the secondary intercostal space or both sides of the sternum. Next step, investigation, X-ray method and endoscopic methods are most effective for early diagnostic of cancer. X-ray diagnosis of benign of malignant stomach ulcer in the early stages is very difficult. X-ray thinks of ulcer malignance are large, nickel more than 2 centimeters, deeper with white infiltration around the irregular of the relief of mucous membrane around the nickel as weakening of muscles wall, contraction cancer. Nickel often has irregular trapezoid shape, high undermined on the edges. More main diagnostics rule is plate endoscopy. It's allow not only visiting the stomach, but also performing target biopsy. Material is taken from several sectors of ulcer. It lasts 5 to 6 biopsies. Histological analysis of early forms of gastric cancer showed what early still small tumors can ulcerate and scar repeatedly was using themselves at gastric ulcer. In this picture, you may see chronic, long-time ulcer, and there are gold standard. You must give a biopsy for histology analysis. Treatment. The scope of operation with an established diagnosis of gastric ulcer malignancy depends on the localization size of the ulcer and the stages of development of the disease. If the tumor is diagnosed on time, then radical treatment is indicated. For tumors of the upper third of the stomach, distal gastrectomy or gastrectomy is performed. For tumors of the lower and middle stomach, a subtataproximal gastrectomy is performed. In any case, surgical intervention are performed according to oncological principles. What means? It means removal of tumor focus together with the lymphatic vessels and regional lymphatic nodes and single blocks with healthy tissue. Without fail, the operation is accompanied by the removal of large and small oil cells. very often use gastrectomy, because it's radical operation. Peptic ulcer of stomach and duodenum complicated by bleeding. You may see in the 39 to 55%, of course, of bleeding from the gastrointestinal tract and gastric ulcer and duodenal ulcer. Peptic ulcer disease is complied by bleeding in 10 to 20% of patients. More often, it's men when in women. Clinical symptoms, bleeding. Clinical manifestation of bleeding from the gastrointestinal zone in a gray or separately vomiting of blood and myeloma. Vomiting of unchanged blood or scarlet or dark cherry color. With massive bleeding with relative rapid blood loss of 500 millimeters and more. In such a situation, condition, hydrochloric acid does not have time to react with large amount of hemoglobin in the blood. Vomiting of unchanged, more often scarlet blood is an important thing of the rate of blood loss. Much more often with gastroduodenal ulcerative bleeding is vomiting with a blood derived hydrochronic hematine, a type of conflagrants. In difficult condition, when it's difficult to be possible due to the color of vomit. No, for example, stagnant liquid or coffee grounds. You should see 3% solution of hydrogen peroxide. Only open contact with blood or its directive the solution forms. The second cardinal symptoms of bleeding from the gastrointestinal zone is myeloma. It is black stool. Indeed, the hemoglobin of blood under the influence of digestive enzymes decompose with the release of iron sulfide of the results of which the stool acquire a characteristic blood color. However, black faces are detected no earlier than 8 hours after the onset of bleeding, and for with a blood loss of 80 millimeters may be sufficient. Decorate black stool occur with light bleeding. Next, empowered complications. Pallor of skin color and visible mucous membrane, nail bed, coldness of the skin, hyperhidrosis, increased respiratory rate, tachycardia, decreased blood pressure. Patients with gastrointestinal bleeding transpirate only on a journal with obliquity accompanied of doctor. Следующее about laboratory diagnostics. A blood test is a viable diagnostic method, decreasing hemoglobin, decreasing the number of erythrocytes, decrease hematocrit, leukocytosis, undoubtedly can exude a severity of blood loss. However, in the first hours after the onset of acute bleeding, all with indication change insignificantly and therefore of relative importance. The true severity of anemia becomes clear clear only after a day or more against the background of hemodilution due to restoration of intravascular volume due to extravascular fluid. And also, if we today talk about bleeding, I must repeat classification by Forest. By Forest, it's international classification. According to this classification, there are three stages. First, Forest 1. Forest 1 maybe A and B. Forest 2 maybe B, A, B, C, and you see on this picture forest 1, forest 1A. It means jet, pulsating arterial bleeding of ulcer. To 1B, it's venous diffusion bleeding from ulcer, but continue. Forest 2A, it means visible larger thrombosis vessels of bottom of ulcer. To be thrombosis clot fixate to the ulcerate basis. To see, it means small thrombosis vessels in the form color spots, and forest free absent or symptoms of bleeding, stigmas of bleeding in the ulcer. It means you see only clean basis of ulcer, clean fibrin. Surgical tactics. At present, when I choose a tactic of treatment patient with bleeding from gastrointestinal ulcer, first of all, it's necessary to take into account the clinical and the endoscopical criteria for stability of hemostasis and the degree of blood loss, as well as possibility of endoscopic sieve in the perform endoscopic hemostasis. For patients with signs of established hemostasis and a high degree of blood loss, the risk of early rebleeding is 70%. At the same time, in almost 70% of patients, early relapse of bleeding occurs without the next 12 to 48 hours. So, for surgical tactic, you may divide patient two groups. In the first group, patient with enjoying bleeding, forest 1. For whole conservative measure include endoscopic methods were ineffective as well as patients with recurrence bleeding in the hospital are subject to emergency surgery. In secondary groups, urgent surgical intervention are indicated in clinical unestablished hemostasis and in the presence of things of a high risk of rebleeding, the stopping of which by conservative and endoscopic methods was insufficient reliable force 2A and force 2B. Patients in the group usually undergo surgery without 12-24 hours from admission, the time required to prepare the patient for surgical. What means conservative treatment? Always you must start with conservative treatment. Conservative treatment, it means stretch bed rest, nasogastric tube, local hypothermia, hunger during the first day, from the moment of stabilization of hemostasis. Next, rational infusion, transfusion therapy. It means colloid, crystalloid, electrolyte solution, and hemostatic therapy, hemostatic therapy. Yes, maybe use component of blood, plasma, erythromassa. Often you must use during conservative treatment. What means hemostatic therapy? Unfortunately, very often, many students do mistake. Don't answer hemostatic therapy. It means you must use etamisolate or else dicinone, aminocapron acid. Maybe today use and the more modern trimexam, chloride calcium, Vigasol, and else you must use next therapy, anti-secretory therapy. Anti-secretory therapy include next groups. It's inhibitor to H2 blocks receptors in inhibitor proton pumps. Else, very important moment. You must use intravenous parenteral forms with drugs and better use Hamatel, use Lasec from inhibitor proton pump groups. And next, standard anti-ulcer therapy after endoscopical confines hemostasis stabilization. It means stabilizate hemostasis. You may use tablets per os drugs for continue your treatment. In this course, you must use Almagel, Almes, amoxicillin. Amoxicillin you must give, you must prescribe if determined Helicobacter pylori. If absent Helicobacter pylori, you must exclude this drug. And that's it. Так, ну, next. Endoscopy hemostasis methods. Endoscopy hemostasis methods. On our lesson, I'm often speak, show video with methods. It's application, injection, thermal, physical, and mechanical methods. What means application methods of hemostasis? Endoscopical adhesive application using slang of spray can, lifuzole, statizole, gastrozole, and medical adhesion-like application create a protective film on the effect area of a mucous membrane, which allow to be protected from the effect of gastric juice. However, they have a hydrophobic property defect health after the treatment with the formation of root scars. Next application methods irrigation of a bleeding surface with solution or silver nitrate. Vagotil causes chemical coagulation and scab formation. The disadvantage in the invisibility of the scab and therefore also ineffective with active bleeding of a high degree of risk of replace are often used in combination with all the drugs of prevention of replace. Next method application is of derivative of inorganic salts, hemostats, container of iron, of aluminium salts in the composition, show a high actively include the continue bleeding as well as in combination with other methods. Next method used for endoscopic hemostasis of insufflation of dry part of the gel sorbent on the bleeding area, the so-called endoscopic sorption hemostasis. Hydrophilic granule sorbent are polymeric agents capable of swelling in aqueous solution to form a soft gel. No, more often use Cefadex, Citadex, Mol-Select drugs for these people. Due to the hydrophility of the sorbent are not washed off by the content of the stomach, but reliable fixate at the site of application. The rejecting periods is 5-7 days. Preventing the effects of the contents of the stomach and effect mucosa. Next method, injection method, very often used because good effect after use with methods. Maybe use solution of aminocapron acid, maybe use vasoconstrictor drugs, adrenaline, noradrenaline, and maybe use sclerosant, ethyl alcohol, etoxysclerol, often used also. The initial hemostasis effect of the injection method and is high and amounted to 19%. But at the same time, the recurrence of bleeding, how it's the injection method, what is the most often used in the combination with our method. Injection given at several points along the rupture mucosa. And the last method, thermal methods of endoscopic hemostasis include various types of thermal effects. The essence of the methods lies, sorry, у меня лекция, я перезвоню. Sorry, stop on thermal methods, okay. With methods good, with methods good, maybe use the next types of these methods. It's argon plasma coagulation is argon. Next, laser photocoagulation, liquid diathermocoagulation also maybe use. The liquid diathermocoagulation is a high frequency coagulation, is performed through the in aqueous electrolyte solution. Coagulation through the electrolytes is devoid of such negative properties as adhesion of coagulated tissue to the electrode. Following by detachment of the scalp when the instrumental is withdrawn from the coagulation site. And the last method is mechanical method of hemostasis, include the application of clips and ligation of rupture zone with latex rings. Very often latex rings don't use because often very difficult stay with rings. Use clips. Effect very good, and finish hemostasis according to same authors. The relapse rate is normal when 4%. However, these methods require consumable and are not always technical feasible due to the difficulty of excessive source of bleeding. It is not technically possible to apply eclipse or latex rings at every option. In practically, a combination of endoscopic hemostasis method, the most often used, which is more effective science, and one method can complement the other. Surgery operation. Gastric resection is recommended for bleeding gastric ulcer in accordance with National Clinic guideline. This method you must use is non-effective endoscopic method stop bleeding. For bleeding duodenal ulcer, the following surgical intervention may be recommended. Pillar duodenal with excision of anterior wall ulcer. Pilaroplastic according to Finney and stem vagotomy. Pilar duodenectomy is stitching of a posterior wall ulcer. Finney pilaroplasty and stem vagotomy. Resection of stomach. And attention. In critical or ill patient, it's possible to perform gastroduodenectomy with suturing of the bleeding vessels at the bottom of the ulcer. It means if you see patient with bleeding, your first task, do hemostasis, use only endoscopic method, stop bleeding, and conservative method. If non-effective, may be used little small operation, suturing with vessels or with ulcer when you visible bleeding. Other method, resection, anastomosis, vagotomy only after acute periods bleeding. After acute periods bleeding. Understand me?
Yes.
Good.
Yes.
Good. Today finish my lecture. It's all information which I speak for you today.